Global public health authorities and multinational epidemiological surveillance teams are actively monitoring a lethal cluster of hantavirus infections linked to an expedition cruise ship in the Atlantic Ocean, an outbreak that directly intersected with South Africa's international transit infrastructure. The incident originated aboard the Dutch-flagged vessel MV Hondius, operated by Ocean-Wide Expeditions, which departed from the southern Argentine port of Ushuaia on April 1, 2026. Carrying 114 passengers and 61 crew members, the ship's itinerary traversed the South Atlantic, including mainland Antarctica and several remote islands. The timeline of the outbreak began silently on April 6, 2026, when an adult male Dutch passenger developed initial clinical symptoms consisting of a fever, headache, and mild diarrhea. By April 11, his condition deteriorated rapidly into severe respiratory distress, resulting in his death while on board the vessel. Because the ship lacked the necessary specialized diagnostic facilities, no immediate microbiological or virological testing could be performed at sea, leaving the cause of death temporarily unverified. +3. The epidemiological trajectory shifted critically to South Africa's largest metropolis, Johannesburg, following a logistical stop at the British Overseas Territory of St. Helena in the South Atlantic. On April 24th, the remains of the deceased passenger were transferred ashore, accompanied by his 69-year-old Dutch widow. The woman was already displaying gastrointestinal symptoms, but was permitted to board a regional Airlink flight on April 25, which carried 82 passengers and 6 crew members directly to OR Tambo International Airport in Johannesburg. Upon arrival in South Africa, she attempted to board KLM Flight 592, a scheduled codeshare flight with Air France, Delta Airlines, and Scandinavian Airlines bound for Amsterdam Schiphol Airport. Recognizing her severe and rapidly deteriorating medical state, the airline crew intervened and denied her boarding before takeoff on the night of April 25. She was urgently transferred to a localized Johannesburg medical facility, where she succumbed to the illness the following day, April 26. It was not until May 4 that laboratory analysis using polymerase chain reaction, or PCR, testing conducted by South African health authorities officially confirmed that her death was caused by a hantavirus infection. +3 to understand why international health agencies responded with immediate urgency. It is essential to look at the specific viral agent identified. Genetic sequencing subsequently performed on 5 separate patients across South Africa, Switzerland, and the Netherlands revealed that the outbreak was driven by the Andes virus. The Andes virus is a distinct species within the orthohantavirus genus, primarily endemic to South America, specifically Argentina and Chile. While most hantaviruses worldwide are strictly transmitted via the inhalation of aerosolized excreta from specific rodent reservoirs with no possibility of human-to-human spread, the Andes virus strain represents a critical exception. It is well documented in medical virology that the Andes virus can be transmitted directly between humans, typically through close, prolonged contact in confined environments. This biological capability instantly transformed a localized maritime incident into a complex, multi-jurisdictional public health emergency, triggering extensive contact tracing across commercial aviation channels and highlighting the vulnerability of international hubs like Johannesburg to emerging zoonotic threats. The unfolding medical crisis forced rapid coordination between the World Health Organization, the European Union, and multiple domestic health ministries as secondary cases began emerging from the MV Hondius. While South African laboratories were working to identify the virus from the deceased Dutch passenger in Johannesburg, a separate clinical emergency occurred simultaneously on the ship. On April 24, 2026, an adult British male passenger presented to the ship's medical doctor exhibiting a febrile illness, severe shortness of breath, and clear clinical signs of acute pneumonia. As his respiratory function sharply declined over the next 48 hours, international emergency protocols were activated. On April 27, the patient was medically evacuated via an airborne transport unit from Ascension Island, another remote territory in the South Atlantic, and flown directly to South Africa. He was immediately admitted into a specialized intensive care unit at a hospital in Johannesburg. On May 2, South African public health officials announced that laboratory testing had definitively confirmed hantavirus infection in this patient. By May 11, South African health authorities reported that while the British national remained under intensive clinical management, his condition was gradually improving. +3, the geographic footprint of the virus expanded further when a third fatality occurred on board the cruise ship on May 2, involving a German female passenger who had developed fever, flu-like symptoms, and subsequent lethal pneumonia. Recognizing an active cluster of severe acute respiratory illness, the World Health Organization formally reclassified the situation as an active hantavirus outbreak on May 4. The vessel arrived at the port of Praia in the West African island nation of Cape Verde on May 3, where it was temporarily held in coastal waters. Local authorities in Cape Verde, determining that their domestic medical infrastructure lacked the specialized containment facilities and biosecure resources to manage a large-scale evacuation safely, kept the passengers on board. During this docking period, medical evacuation flights were arranged to remove 3 high-risk individuals from the ship, including the ship's medical doctor, a 41-year-old Dutch national, a 56-year-old British crew member, and a 65-year-old German national. These individuals were airlifted to specialized containment facilities in Europe, with laboratory testing conducted in Senegal subsequently confirming hantavirus infection in 2 of the evacuees. +4, with the approval of Spanish health authorities and under a joint framework between the World Health Organization's Emergency Medical Team Secretariat and the European Union Emergency Response Coordination Center, the MV Hondius departed Cape Verde on May 6, bound for Spain's Canary Islands. The ship arrived at Tenerife on May 10, carrying the remaining 147 passengers and crew. A massive, highly controlled international repatriation operation commenced immediately at the Tenerife Sir Reina Sofia Airport. Passengers disembarked directly onto non-commercial, chartered aircraft bound for over 20 countries, preventing exposure to the general public. Domestic health agencies immediately countered initial public anxieties by contrasting the severe clinical presentation of the virus with its actual epidemiological risk. World Health Organization Director General Tedros Adhanom Ghebreyesus stated that while the condition of some patients was critical, citizens worldwide should understand there is nothing to fear, as the general public risk remains low. The top epidemic expert for the World Health Organization, Maria van Kerkhove, explicitly emphasized that this is not the next COVID-19, noting that the virus is far less contagious and that public health measures are fully capable of halting its progression. Managing the aftermath of the MV Hondius outbreak relies heavily on strict, standardized global public health protocols designed to break any potential chains of human-to-human transmission. Because the incubation period for hantaviruses is characteristically prolonged, typically ranging from 1 week to 6 or even 8 weeks. The World Health Organization has issued a mandatory recommendation for a 42 to 45-day active monitoring and quarantine period for all individuals who were on board the vessel. Domestic health departments have implemented varying degrees of isolation based on exposure levels. In the United Kingdom, the Health Security Agency evacuated 20 British nationals, alongside a German resident and a Japanese passenger, transferring them to a hospital facility in northwest England for structured monitoring and long-term isolation placement. In the United States, Acting Centers for Disease Control and Prevention Director Jay Bhattacharya confirmed that 17 American passengers had arrived back in the country, with 15 individuals entering the National Quarantine Unit in Nebraska, and 1 individual who displayed initial positive indicators being placed within a specialized biocontainment unit. French health authorities under Prime Minister Sébastien Lecornu placed 22 returning citizens under surveillance, with 8 individuals subjected to reinforced isolation protocols due to their status as high-risk close contacts of the Dutch passenger who died in Johannesburg. +2, for general public guidance and preventive mechanics, epidemiological organizations emphasize that standard hantavirus prevention revolves around mitigating contact with rodent reservoirs, which shed the virus in their urine, feces, and saliva. In standard terrestrial settings, transmission occurs when individuals disturb contaminated materials, causing viral particles to become suspended in the air. Public health instructions strictly warn against dry sweeping or vacuuming areas suspected of rodent infestation, as these mechanical actions forcefully aerosolize the pathogen into fine particles that are easily inhaled into the respiratory tract. Instead, guidelines call for the thorough dampening of surfaces with liquid disinfectants and the mandatory use of well-fitted N95 particulate respirators. On board the MV Hondius, where 30 crew members remained to sail the ship back to the Netherlands, operations focused on rigorous environmental cleaning, enhanced mechanical ventilation, and total avoidance of dry cleaning methods before full disinfection could occur upon arrival. +1 honest limits of knowledge remain a core component of official briefings. While genetic sequencing verified a single zoonotic spillover event, indicating that the patients were infected from a common source rather than an uncontained multi-generational chain of human-to-human transmission. The exact mechanism and physical location where the initial exposure occurred on the ship or during its mainland South American excursions remains under active investigation. Furthermore, medical science continues to acknowledge that there is no specific cure, antiviral treatment, or vaccine for hantavirus pulmonary syndrome. Clinical care remains entirely supportive, relying on early detection, oxygen therapy, and mechanical ventilation to stabilize patient blood pressure and respiratory function. Public health systems emphasize that the stringent measures applied globally are a precautionary response to a severe pathogen rather than an indicator of a widespread threat to communities. For continued verified updates on global public health reporting and breaking epidemiological news, consider subscribing to this channel. The clinical and logistical center of the hantavirus crisis shifted to Johannesburg on April 27, 2026, with the high-stakes medical evacuation of a 48-year-old British male passenger. The patient, whose condition had deteriorated while the MV Hondius was at sea, was transported via an airborne intensive care unit from Ascension Island directly to a specialized hospital in South Africa's Gauteng province. Upon arrival, the patient was in a state of advanced respiratory failure, a hallmark of hantavirus pulmonary syndrome. Medical teams in Johannesburg reported that the patient exhibited severe pulmonary edema and required immediate mechanical ventilation to maintain blood oxygen levels. While the patient's condition remained critical for several days, South African health officials confirmed on May 2 that molecular diagnostic testing had returned a positive result for hantavirus, marking the second confirmed case linked to the vessel to be treated within the city. By May 11, clinicians observed a stabilization in his vitals, noting a gradual improvement that allowed for a guarded but optimistic prognosis. Though he remained under strict isolation protocols to prevent any potential hospital-acquired transmission, as clinical teams in South Africa managed the primary casualties, a secondary maritime crisis unfolded off the coast of West Africa. On May 3, the MV Hondius arrived at the port of Praia in Cape Verde, where local health authorities were forced to make a critical determination regarding the vessel's 175 remaining occupants. After reviewing the ship's medical logs and the escalating number of symptomatic passengers, the Cape Verdean government determined that its domestic healthcare infrastructure lacked the high containment, biosafety level 4, facilities required to manage an Andes variant hantavirus outbreak safely. Consequently, the ship was denied permission to dock and was held in a strictly enforced maritime quarantine in coastal waters. During this standoff, medical samples from 3 symptomatic individuals on board were expedited to the Institut Pasteur in Dakar, Senegal, a regional hub for viral hemorrhagic fever and zoonotic disease research. On May 5, the laboratory confirmed that at least 2 of the 3 new suspected cases were positive for hantavirus. This confirmation led to the urgent medical evacuation of the ship's Dutch medical doctor, a British crew member, and a German national, all of whom were airlifted to specialized containment centers in Europe to alleviate the mounting pressure on the ship's limited infirmary. The logistical complexity reached its peak on May 6, when the vessel was permitted to depart Cape Verdean waters for the Spanish Canary Islands under a coordinated plan involving the World Health Organization's Emergency Medical Team's Secretariat and the European Union's Emergency Response Coordination Center. The ship arrived at the port of Santa Cruz de Tenerife on May 10, initiating one of the largest and most complex international repatriation efforts in recent maritime history. To prevent the virus from entering the local population, Spanish authorities established a sterile corridor between the port and the Tenerife Sir Reina Sofia Airport. The 147 remaining passengers and crew members were categorized by their level of exposure and clinical symptoms before being moved directly onto a fleet of chartered aircraft. These non-commercial flights were bound for over 20 different countries, including the United Kingdom, Germany, the United States, and France. This bridge operation was designed to bypass traditional terminal procedures, ensuring that no individual from the ship interacted with the general traveling public during the transition from sea to air transport. Throughout these core developments, international health agencies worked to reconcile the severity of the individual cases with the overall threat to global health. The World Health Organization officially designated the events as a localized outbreak on May 4, triggered by the cluster of 3 deaths and multiple confirmed infections. However, officials were careful to contrast the lethality of the virus with its relatively low transmission rate. World Health Organization Director General Tedros Adhanom Ghebreyesus issued a formal statement clarifying that while the clinical manifestation of the Andes virus is grave for those infected, the outbreak was contained within an identifiable cohort of travelers. Maria Van Kerkhove, leading the WHO's epidemic response, emphasized that because the virus primarily spreads through heavy, close contact or specific environmental exposure, it did not possess the same pandemic potential as highly contagious respiratory viruses like influenza or coronaviruses. The contrast between the intense, high-security medical response in Johannesburg and the calm, data-driven messaging from Geneva reflected a strategy of containment through precision rather than general public alarm, focusing the world's resources on the specific point of origin and the identified transit path of the vessel. As the international repatriation phase of the MV Hondius outbreak concludes, global public health efforts have shifted toward an intensive 42 to 45-day monitoring and quarantine window. This period is critical because hantaviruses are characterized by a notably long and variable incubation period, often remaining asymptomatic for several weeks before the sudden onset of severe respiratory or hemorrhagic symptoms. In the United Kingdom, the Health Security Agency has overseen the transfer of 20 British nationals, alongside a German resident and a Japanese passenger, to a specialized hospital facility in northwest England. These individuals are currently placed in structured isolation to ensure that any late-emerging symptoms are captured within a controlled environment. Similarly, in the United States, the Centers for Disease Control and Prevention confirmed that 17 American passengers returned via chartered transit. 15 were admitted to the National Quarantine Unit in Nebraska, while 1 passenger exhibiting suspicious clinical markers was directed to a high-level biocontainment unit for diagnostic clarity. French authorities have mirroring protocols in place for 22 of their citizens, with Prime Minister Sébastien Lecornu's administration designating 8 individuals as high-risk close contacts requiring reinforced isolation due to their proximity to the fatal Dutch case in Johannesburg for the general public. The primary takeaway from this incident is the specific nature of hantavirus transmission and the necessity of targeted environmental precautions. Unlike more common respiratory viruses, hantaviruses are zoonotic, meaning they reside in animal reservoirs, specifically certain species of rodents like the long-tailed pygmy rice rat endemic to South America. The virus is shed in the urine, saliva, and feces of these animals. Transmission to humans occurs most frequently through the inhalation of aerosolized particles. Public health guidance strictly emphasizes that in areas where rodent activity is suspected, individuals must avoid dry sweeping or vacuuming, as these actions launch dried viral matter into the air where it can be easily inhaled. Instead, the standard protocol involves the heavy application of disinfectants or bleach solutions to wet-down surfaces before cleaning, combined with the use of N95 particulate respirators. On the MV Hondius, current maritime operations are focused on these exact deep cleaning protocols as a skeleton crew sails the vessel back to its home port in the Netherlands, ensuring that all environmental reservoirs within the ship's ventilation and storage systems are neutralized. Medical and ethical challenges remain at the forefront of the global response, particularly regarding the limits of current science. There is currently no World Health Organization approved vaccine or specific antiviral therapy for hantavirus pulmonary syndrome. Clinical management is limited to aggressive supportive care, including the use of mechanical ventilators or extracorporeal membrane oxygenation, known as ECMO, to oxygenate the blood when the lungs fail. While genetic sequencing has confirmed that the MV Hondius cases originated from a single zoonotic spillover event, meaning a group was exposed to a single source rather than a continuous chain of person-to-person infections, the exact physical location of that exposure remains unknown. Investigators are still analyzing whether the infection occurred during mainland excursions in Argentina or through an undetected rodent presence on the vessel itself. This uncertainty highlights the ongoing need for rigorous maritime health surveillance and the ethical necessity of transparent reporting. The incident serves as a stark reminder that in a highly connected global transit network, a single biological event in a remote region can necessitate a multi-continental medical response. Authorities maintain that while the individual lethality of the Andes virus is high, the swift activation of international quarantine protocols has effectively mitigated the risk to the broader global population. For ongoing coverage of emerging public health threats and global medical analysis,